Hey everyone, welcome back to the channel. Have you ever had this experience? You go in for your yearly physical, or maybe you have a little ache or pain, they run some tests, and suddenly they're finding, and the very first thing that pops into your head, and sometimes the first thing the doctor suggests is, let's cut it out, let's just remove the problem. We have this idea that if we just take it out, we've solved it forever, right? I'm here to tell you, as a family physician who's been doing this for over a decade, that way of thinking isn't always correct. And in some situations, especially for patients in a certain age group, it can actually be pretty dangerous. There's something in medicine that we don't talk about enough, and it's this kind of hidden milestone around age 67. After that point, the whole risk benefit calculation for surgery changes in a big way. A lot of people don't realize this, but when you're past that age, going under the knife to remove something doesn't always give you the carefree retirement, the comfortable, active, independent retirement you imagined too often. What it gives you is a long list of complications. Months or years of being bedridden or struggling to recover, and a complete loss of the quality of life you were trying to protect. We've all heard the heartbreaking story. The surgery was technically a success, but the patient was never the same. They just went downhill. So today, I want to walk you through 6 specific types of surgeries. If you're over 67, or if you're caring for someone who is, these are the ones where you really need to pause, take a breath, and have a much deeper conversation with your doctor before signing that consent form. I'm not saying this to scare you. I'm saying this because I want you and your family to have a guide, a dignity preservation guide, if you will, for making decisions at a crossroads where the wrong turn can cost you your independence. Please watch this all the way through, and if it resonates with you, forward it to your friends, your siblings, your parents, because when you're facing one of these decisions, having this information ahead of time can help you avoid the biggest regrets. After 67, as a general rule, we want to prioritize conservative care, treatments that don't involve going into the body before we even think about surgery. So here are the 6 procedures to be extremely thoughtful about. Number 1 is spinal surgery, particularly for lower back problems like herniated discs or spinal stenosis. This is probably the most common issue I see in my older patients. You wake up stiff, your back hurts, maybe you have some shooting pain down your leg. It's incredibly common as we age. So you go see a specialist, they send you for an MRI, and you sit down in their office. They pull up the images on the screen and they point to a disc that's bulging or a nerve that looks compressed, and they say, see this, this is the problem. It's pressing on your nerve. We should operate. Well, go in, remove the part that's pressing, maybe put in some metal screws and rods to fuse it all together. It sounds so straightforward, doesn't it? You see the problem on the screen, you fix the problem, and the pain goes away. But the truth is way more complicated than that. First, we have to understand something basic about how the body ages. After 67, lower back pain is almost never just about one disc. It's about the entire system getting older. We're talking about osteoporosis, where the bones become less dense and more brittle. We're talking about sarcopenia, the natural loss of muscle mass. We're talking about ligaments that have stretched out and don't provide the same support they used to. Here's an analogy I use with my patients. Imagine your spine is like an old wooden beam holding up your house. Over the years, that wood has gotten dry, it's gotten brittle, it's lost some of its strength. Now, imagine you take that old brittle beam and you decide to reinforce it by driving steel bolts deep into it. What's going to happen? The wood is so soft that the bolts don't actually hold. They strip out, they loosen over time. They might even cause the wood to crack and splinter around them. That's exactly what can happen when you put metal hardware into osteoporotic bone. The screws don't hold, they loosen, they can even cause fractures in the surrounding bone. This is why so many older adults end up with more pain after back surgery, not less. The hardware that was supposed to fix them becomes a new source of problems. There's actually a term for this in the medical literature. It's called failed back surgery syndrome. And the statistics are pretty striking in patients over 70 who undergo a lumbar fusion. That's the surgery where they put in the rods and screws. The rate of being readmitted to the hospital within 1 year for complications is over 20%. Let that sink in. 1 out of every 5 patients ends up back in the hospital within a year, and that's just the readmission rate. The surgery itself is a major physiological event. You're put under general anesthesia, which is harder on the heart and lungs as we age. They have to cut through muscles, they have to retract nerves to get to the spine, and nerves in older adults are fragile. If they're pulled or stretched even a little too much, you can end up with permanent numbness. weakness in the legs or even loss of bowel and bladder control. So you went in complaining of back pain and you come out unable to walk properly or control your bladder. That's not a win. That's a tragedy. So what do you do instead? Do you just have to live with the pain? Absolutely not. For the vast majority of patients over 67, conservative care is the smarter, safer path, but it requires a mindset shift. Instead of trying to eliminate the pain completely, we focus on managing it. We accept that some degree of discomfort is part of aging, and we work on keeping you as functional and active as possible. Here's what I typically recommend. First, physical therapy. This can include things like heat and ice, therapeutic ultrasound, hands-on manual therapy, and sometimes acupuncture. These approaches are slower, but they're safe. Second, and this is the big one, core muscle strengthening. A lot of back pain isn't actually from the disc, it's from the muscles around the spine being too weak to support it. When you work with a physical therapist to strengthen those deep core muscles, you're building your body's own natural back brace. That's often more effective in the long run than metal hardware. Third, smart pain management. Don't be afraid of medications. The risks of appropriately using over-the-counter or prescription pain relievers are usually much, much lower than the risks of a major spinal surgery under general anesthesia. Here's the bottom line, and I want you to remember this: operating on the spine should always be the last resort. It's the card you play only after every conservative option has failed, and only when your quality of life is so severely affected that you can't function. Things like losing control of your bowels or bladder, or having muscles that are actually becoming paralyzed. It is not, and should never be, the first option. Number two is gallbladder removal for what we call silent gallstones. With all the screening tests and routine physicals we do now, it's very common for someone to have an ultrasound of their abdomen for some other reason and find out, oh, you have gallstones, or maybe they find a polyp on the gallbladder. And a lot of doctors, especially surgeons, will say, you've got stones in there. It's a ticking time bomb. Let's just take that gallbladder out. You don't really need it anyway. I hear this all the time. But is that really the right approach for someone over 67? If your gallstones are silent, meaning they don't cause you any symptoms, you don't have pain after eating, you've never had a gallbladder attack, no nausea, no nothing, then my strong advice is to leave them alone. Let me explain why, and I want you to think about it like a simple risk calculation. First, let's look at the probability that those silent stones will ever actually cause a problem. Large population studies show that for people with asymptomatic gallstones, the chance that they will develop a serious complication over the next 10 years, like acute cholecystitis, which is an infection of the gallbladder, or gallbladder cancer, is extremely low. We're talking less than 2%. So you would be accepting 100% of the surgical risk, the risk of anesthesia, the risk of infection, the risk of complications, for a 2% chance of a future problem. That math just doesn't add up. Second, let's look at the cost of surgery, and I don't just mean the financial cost. Though that's significant even with Medicare or private insurance, I mean the cost to your body and your quality of life. Even though gallbladder removal today is usually done laparoscopically with just a few small incisions and a short hospital stay, it's still a major procedure. It requires general anesthesia. They have to inflate your abdomen with gas to create space to work, which puts extra strain on your heart and lungs. And then there's something called post-cholecystectomy syndrome. What is that? Your gallbladder acts like a reservoir. It stores bile that your liver makes. And when you eat a meal, especially a fatty meal, it contracts and releases a concentrated burst of bile into your intestine to help digest that fat. When you remove the gallbladder, that reservoir is gone. Bile just constantly trickles into your intestine like a faucet that never quite turns off. For a lot of people, this means chronic diarrhea, especially after eating anything with fat. It can mean bloating, gas, and something called bile reflux, where bile backs up into your stomach and even your esophagus, causing a burning sensation that can keep you up at night. A younger person's body can often adapt to this over a few months. But for someone over 67 whose digestive system is already more sensitive, losing the gallbladder can mean a lifelong struggle with unpredictable bowels and digestive discomfort. That's a massive hit to your quality of life. You traded a 2% risk of a future problem for a daily reality of diarrhea and indigestion. So here's my advice: if your gallbladder isn't bothering you, don't bother it. Let it live in peace inside your body. If you ever develop symptoms, pain in the upper right part of your belly, fever, nausea, or jaundice, which is yellowing of your skin or the whites of your eyes, then we have that conversation about surgery. Until then, focus on the things you can control. Eat a balanced diet, maybe go easy on the super greasy fast food, and don't skip meals, especially breakfast. For most people, that's enough to keep things calm. Number three is surgery for an enlarged prostate or benign prostatic hyperplasia, which we call BPH. This one is specifically for the men watching or for the women who love a man with an enlarged prostate. An enlarged prostate is essentially a normal part of aging for men. By the time you're 67, I'd estimate that 8 out of 10 guys have some symptoms, you know what I'm talking about. Getting up multiple times at night to pee, a stream that's weak and takes forever, that feeling like you're never quite empty. It's frustrating, it disrupts your sleep, and it can really affect your quality of life. You go to the urologist, and they might say your prostate is pretty enlarged. We can do a TURP, a transurethral resection of the prostate. It's a scope. We go in through the urethra and we shave away the excess prostate tissue that's blocking the flow. It opens everything right up. It sounds like a routine procedure, and for many men it is, but for older men, the risks are often underestimated. We have to think very carefully about what life looks like after the surgery. The prostate sits in a really tricky spot right at the base of the bladder surrounding the urethra. All around it are the nerves and muscles that control urination and sexual function. After 67, the sphincter, that's the circular muscle that acts like a drawstring to hold your urine in, is already a little weaker just from age. During surgery, if that muscle gets even slightly damaged, or if the healing process isn't perfect, the direct result can be stress incontinence. That means leaking urine when you cough, sneeze, laugh, or just move around. Think about what that means for a moment. A man's main problem was getting up a few times at night. Annoying, yes, but he could manage it. He could still go to dinner with friends, still go to church, still volunteer. After surgery, if he ends up with incontinence, has wearing adult diapers, has constantly worried about smell, has hesitant to leave the house, he becomes isolated. That is absolutely devastating to a person's dignity and mental health. And incontinence isn't the only risk. There's also something called retrograde ejaculation, where semen goes backward into the bladder instead of out. There's the risk of urethral strictures, where scar tissue narrows the urethra again, sometimes making the urinary symptoms worse than before. There's the risk of stubborn, recurrent urinary tract infections. The rates of all these complications go up significantly with age. Some studies show that in men over 70, the rate of getting truly excellent durable symptom relief from a TURP is less than 60%. That means 4 out of every 10 men go through a major procedure, deal with the recovery and the risks, and their problem isn't fixed, or it's worse. So what's the alternative if you're struggling to urinate for men with mild, moderate, and even some severe symptoms? Medications are not only effective, they're much safer. We have several classes of medications that work really well. Some relax the smooth muscle of the prostate and bladder neck, making it easier to urinate. Others actually shrink the size of the prostate over time. As long as you're still able to empty your bladder, as long as you don't have complications like kidney damage from back pressure or repeated blood in your urine or bladder stones, then medication is absolutely where we should start if it truly becomes blocked and you can't urinate at all. That's a medical emergency called acute urinary retention. Then surgery may be necessary. But if you do need surgery, go into it with your eyes wide open. Understand that the recovery can be long. Understand that you will likely need to work with a pelvic floor physical therapist afterward to retrain those muscles and regain control. This is not like fixing a leaky pipe. This is delicate, complex tissue, and the outcomes aren't guaranteed. Number 4 is knee replacement surgery. This is one of the most common procedures I see people excited about, and also one of the most misunderstood. Knee replacement is a huge business now. You can't watch television without seeing an ad, "Get your life back, new knee, no more pain." You see some smiling 70-year-old on a hiking trail or dancing at their grandkid's wedding. And for a lot of my patients who have struggled with knee pain for years, that image is incredibly tempting. They think, if I just get the surgery, I'll be that person. I'll be able to do all the things I used to do, but there's a huge misconception here that I need to clear up. A knee replacement replaces the joint surfaces, the bone and cartilage that have worn away. It does not replace your muscles. It's like putting a brand new Top of the line tire on a car that has a seized engine and worn out suspension, that new tire looks great, but the car still isn't going anywhere. After 67, a lot of people not only have worn out knees, they also have sarcopenia, that age-related loss of muscle mass and strength I mentioned earlier. The quadriceps muscles in the front of the thigh, which are the primary muscles that control the knee, are often weak and wasted from years of disuse due to pain. A total knee replacement is a massive surgery. The surgeon has to cut through bone, remove the damaged surfaces, and hammer and cement metal and plastic components into place. The pain after this surgery is often far more intense than people are prepared for. We're talking about pain that can be difficult to control even with strong narcotics, and then comes the really hard part, the rehabilitation. The surgery itself can be absolutely perfect. The alignment is great. The components are well placed, but if you don't go through weeks or months of grueling, often painful physical therapy to rebuild that muscle strength, that new joint is essentially useless. The muscles aren't strong enough to control it. That leads to instability, a feeling that the knee might give out. It increases the risk of falling. And a fall for an older adult can be catastrophic. Hip fractures, head injuries, a cascade of decline. The implants can even loosen over time if the muscles aren't holding everything in place. I see this scenario in my practice all too often. A patient, let's call her Margaret, spends a lot of money. Even with good insurance, there are copays, deductibles, time off work for her spouse who cares for her. She goes through the pain of surgery, the hospital stay, the initial recovery, but then when it's time for the hard work of rehab, she's too afraid of the pain, or she tries, but her muscles were so weak beforehand that she just can't make progress. The end result, her knee pain might be gone, but her leg is stiff and weak. She still can't walk more than a few steps without a walker. Sometimes she ends up in a wheelchair. She traded one kind of disability for another. So how do you know if you're a good candidate? Don't just look at the x-ray. Don't just look at how worn out the cartilage looks. You have to look at the whole picture. I ask my patients to consider three things. First, your actual activity level. If your daily life consists of walking around the house, going to the grocery store with a cart, maybe a short walk in the neighborhood, and your pain is manageable with things like Tylenol, maybe an occasional cortisone shot, or using a cane, then you likely do not need a knee replacement. Second, your muscle strength. If you have trouble lifting your leg off the bed when you're lying down, you need to work on strengthening those muscles before you even think about surgery. If you can't build that foundation, the surgery won't give you the result you want. Third, your overall health. Do you have poorly controlled diabetes? That dramatically increases the risk of infection. Do you have significant heart disease? That increases the risk of complications from anesthesia and the stress of surgery. An infection in a new knee joint is a disaster. Sometimes the only solution is to remove the implant entirely, leaving you with a fused knee or no joint at all. The pain and suffering from that is almost unimaginable for the majority of older adults with lower activity demands. The wisest path is conservative care. That means maintaining a healthy weight. Every extra pound is extra force on that knee. It means using assistive devices like a cane or a walker without shame. It means doing gentle, consistent exercises to keep the muscles as strong as possible. Using a cane is not a sign of failure. It's a sign of wisdom. It's far better to use a cane and stay active than to take a huge surgical risk and end up unable to walk at all. Number 5 is surgery for certain types of tumors, and I know this one can be emotionally charged, so let's talk about it carefully. In our culture, the word tumor or cancer triggers an immediate fear response. The instinct is it has to come out, it's the enemy, and we need to cut it out to be safe. But for someone over 67, especially when we're talking about slow-growing, low-grade malignancies, we need to have a more nuanced conversation. We have to weigh the benefit of removing the tumor against the cost of the surgery on their overall quality of life. The classic examples here are things like low-risk prostate cancer, certain types of thyroid cancer, and some early-stage, slow-growing breast cancers. We have a nickname for some of these in medicine. We call them indolent cancers or lazy cancers. They grow so incredibly slowly that they might not cause any problems for 10, 15, even 20 years. Now, imagine an 80-year-old man who is diagnosed with a low-risk prostate cancer, is otherwise fairly healthy if we do nothing but monitor him, what we call active surveillance. he might live another 5, 8, or 10 years, and eventually he might pass away from something completely different, maybe a heart attack, maybe complications from a flu infection, maybe just old age. That prostate cancer would never have bothered him. It would have been an incidental finding, not the thing that defined his final years. That's what we mean by living with cancer. But if we insist on operating, if we put him through a radical prostatectomy, the stress of major surgery, the general anesthesia, the hit to his immune system from such a big procedure, this can sometimes tip a fragile balance. I have seen patients who were doing reasonably well before surgery, eating okay, moving around, enjoying time with family, and after the surgery, they never really bounce back. Their body just can't handle the insult, the trauma of the operation, the hospitalization, the immobility during recovery can weaken them to the point where something else takes over. And there's even a theoretical concern that the immune suppression from major surgery could allow any remaining cancer cells to grow more aggressively. The research backs this up. Large studies on low-risk prostate cancer in men over 75 show that those who choose active surveillance, regular checkups, PSA blood tests, maybe an occasional biopsy, have essentially the same 10-year survival rate as those who underwent aggressive surgery or radiation. If you're going to live just as long either way, why would you choose the path that involves a major operation, a hospital stay? And a high risk of side effects like incontinence and sexual dysfunction, why risk those complications in the final years of your life? Now, to be perfectly clear, this does not apply to all cancers. If it's an aggressive, fast-growing tumor that's blocking a vital structure, causing significant pain, or clearly threatening to spread, then surgery may absolutely be the right and necessary choice. But for those lazy cancers, we have to resist the knee-jerk reaction to cut. We have to listen to our oncologists, our surgeons, and really consider the full picture. Sometimes the most aggressive treatment is not treatment at all. But careful watching sometimes, not operating, means you actually live longer and with far more dignity. It's a different way of thinking, but it's an important one. Number 6 is heart surgery, specifically bypass surgery or stent placement for stable blockages. This is a topic that comes up constantly in my clinic. Heart disease is the leading cause of death in this country, so when someone hears that their coronary arteries are blocked, the anxiety is immediate and intense. The family hears 75% blockage and they panic. They say, stent, bypass, we have to do something now before he drops dead of a heart attack. I understand that fear. I really do. But for someone over 67, especially if they have other chronic conditions like diabetes, high blood pressure, kidney disease, or peripheral vascular disease, the benefit of these invasive procedures is not always clear-cut. In fact, sometimes the risks outweigh the benefits. We have to make a crucial distinction here. If you are having an active heart attack, if you're experiencing chest pain, shortness of breath, and the EKG shows that a part of your heart muscle is actively dying, that is a medical emergency in that situation. Going to the cath lab to open the blocked artery with a stent or emergency bypass is absolutely the right call. It's life-saving, and we do it without hesitation. But if you have stable angina, that's a different story. Stable angina means you might get chest tightness or pressure when you exert yourself, walking up a hill, carrying groceries, shoveling snow, but it goes away completely with rest for stable angina. The decision is much more complicated. Large, well-designed international studies, including one called the ischemia trial, have shown that for patients with stable coronary disease, starting with optimal medical therapy, medications like aspirin to prevent clots, statins to lower cholesterol and stabilize plaque, and blood pressure medications is just as effective as getting a stent or bypass at preventing future heart attacks or death. But medical therapy doesn't come with the risks of an invasive procedure, and those risks are real. The arteries in older adults are often not just blocked, but heavily calcified. They're hard, brittle like stone. Trying to place a stent in those arteries is technically difficult and carries a higher risk of complications like dissection or rupture of the artery. Bypass surgery is open heart surgery. It's a massive operation that requires stopping the heart and putting the patient on a heart-lung machine. That puts an enormous strain on every organ system, especially the kidneys and the brain. I have seen patients where the cardiac surgery was technically successful, the grafts were perfect, the blockages were bypassed, but they ended up on permanent dialysis because their kidneys failed from the stress of the surgery, or they had a stroke during the procedure and woke up with permanent brain damage. The heart is fixed, but their life is completely changed. They're dependent on caregivers, maybe in a nursing home. So here's my advice. If your symptoms are well controlled with medication, if you can do your daily activities, enjoy time with your family, and not be limited by chest pain, do not let anyone push you into a procedure just to make the angiogram picture look prettier. The goal of treatment is not to have perfect looking arteries on a scan. The goal is for you to live a long, active, enjoyable life, focus on managing your risk factors, take your medications consistently, work on your diet, manage your stress, get gentle, regular exercise as you're able for stable coronary disease. That approach is often the most effective and the safest. I know that was a tremendous amount of information, and I appreciate you sticking with me. This is a heavy topic, but it's one that affects so many families. So let's take a moment to summarize the key points, and then I want to give you a simple practical tool you can use if you or a loved one is ever facing a surgical decision. Here are the 6 surgeries to be very thoughtful about after age 67. First, spinal surgery, putting metal hardware into brittle, osteoporotic bone can lead to loosening, failure, and more pain. Prioritize physical therapy and core strengthening. Second, gallbladder removal for silent, asymptomatic stones. If it's not causing symptoms, leave it alone. Removing it can lead to chronic diarrhea and indigestion that significantly reduces quality of life. Third, prostate surgery for BPH. The risk of incontinence and other complications is high. Medications are often very effective and much safer. Fourth, knee replacement. It replaces the joint, but it doesn't replace your muscles. Without strong muscles and a commitment to intense rehabilitation, you won't get a good result. Conservative care and using a cane are often the wiser choice. Fifth, surgery for slow-growing, indolent cancers for low-risk prostate, thyroid or breast cancers in older adults, active surveillance living with the tumor. Often results in the same life expectancy without the risks and side effects of surgery. Sixth, heart surgery for stable blockages. For stable angina, the risks of stents or bypass often outweigh the benefits. Optimal medical therapy is a powerful and safe alternative. And here's a simple checklist I call the 3 questions before you cut. If a doctor recommends surgery, take a breath. It's okay to pause. It's okay to say, can I go home and think about this overnight? Before you sign that consent form, ask yourself and your doctor these 3 questions. First, is this surgery absolutely necessary, or is it elective? Let me translate that into plain English. If we don't do this surgery tomorrow, will I die? Will I become permanently paralyzed? Will I lose a vital function? Or is this a situation where the surgery might make things a little better, but it's not an emergency? If it's the latter, if it's elective or optional, for someone over 67, the default should be to try conservative care first. Second, have we truly given conservative treatment a fair chance? We live in a culture that wants quick fixes, a week of pills, 1 physical therapy session. That's not a fair trial. Give your body time. Sometimes a few months of consistent effort with medication, therapy, and lifestyle changes can completely change the picture. Don't give up on conservative options too quickly. Third, and this is the most important one, will my quality of life after surgery honestly be better than it is right now? Don't just focus on the surgeon's success rate at removing the problem. Ask about the recovery rate. Will you be able to get out of bed by yourself? Will you be able to walk to the bathroom? Will you be able to dress yourself, feed yourself, enjoy time with your family? If the answer is probably not, or we're not sure, then that is not a successful outcome, regardless of what the post-op scans show, friends after 67. Our bodies are like a well-traveled airplane. The paint might be a little faded. The engines might make a little more noise. Some of the gauges on the dashboard might not be perfectly accurate, but that doesn't mean we need to take the whole plane apart and rebuild it. What it needs is smart, careful, ongoing maintenance to keep it flying smoothly for as long as possible. The doctors I respect most aren't the ones who operate on everyone. They're the ones who have the wisdom to know when surgery is truly necessary and the humility and courage to know when it's not. That's the kind of doctor I try to be every day. I hope this video, as long and as serious as it was, gives you a useful framework for having these important conversations with your doctors and your family to help you remember the key points. Let's do one more quick recap. Point 1, after 67, be very thoughtful about these 6 procedures: spinal fusion, gallbladder removal for silent stones, prostate surgery, knee replacement surgery for slow-growing cancers, and stents or bypass for stable heart disease. Point 2, if surgery is suggested, use the 3 questions before you cut. Is it truly an emergency? Have we really tried conservative options? And will my life after surgery honestly be better? Please share this video with the people in your life. Share it with your parents, your spouse, your friends. Having this information ahead of time can give them the confidence to ask the right questions and make a choice that protects their independence, their dignity, and their quality of life. If you found this helpful, please give it a thumbs up and drop a comment below. I'd love to hear your experiences. Your questions or your thoughts, I read them all. And as always, a quick but important reminder, this video is for educational purposes only. It's not a substitute for professional medical advice. Always consult with your own doctor before making any changes to your health plan. If you're dealing with any health concerns, please schedule a visit with your primary care provider. I'm here to help you understand the science, not to replace your doctor's expertise. Thanks for watching, take care, and I'll see you in the next video.